Now, you do have some people who are always going to test positive for MAN2 because they received the BCG earlier in their lives. Okay, if they have told you that they did indeed receive the BCG earlier in their lives, what do? Chest X-ray. Okay, don't take the chance. If they say they didn't, they don't know, then, you might want to ask them, well, what country did you grow up in? Because there are some countries where everybody blanket got the BCG. Okay, I know in Haiti, pretty much everyone got the BCG. In the Philippines, at a certain period of time, everyone got the BCG as well. So you might want to ask them that. Okay? The only reason I say this is because I got to tell you, there was a lovely girl who works down in Florida. She was from Haiti, and she went for her MAN2 skin test, and she just couldn't remember. She didn't know if she got a BCG or not as a little child. Well, they said, we got to give you this thing, and if you react positively, then we'll do a chest X-ray. They gave her that 0.1 cc right in her left forearm. Do you know her entire left forearm inflamed up? It swelled out. It just like Popeye the Sailor Man. It was huge. This poor child. So that was uncalled for. All right, so we might need to ask a little further questions, okay? And if we know these things, when in doubt, go with a chest X-ray. I mean, if she comes from a country where you know that BCGs were being given, she doesn't remember, go with the chest X-ray. Really. The other thing is a sputum. You want to obtain a sputum. When is the best time to obtain a sputum? First thing in the morning. Early morning sputum is the best. Now, a lot of times you'll hear this, sputum times 3. Okay, that means 3 days. 3 consecutive days, not 3 sputums. In other words, don't go hap, shoot, hap, shoot, hap. Don't do that. That does not work. Okay. Okay, patient with tuberculosis is a very sick puppy. That is a sick puppy. Yes? That is a sick puppy. Okay. Not a happy camper. We need to implement lots of things for this one. We need to implement respiratory isolation, good hygiene. We want to give him this disposable sputum container. Nothing worse than to have a never mind tuberculosis. Any patient just go, patooey on the, ooh. I saw that the other day in Charlotte. This kid just cleared his throat and spat on the floor. Oh my gosh, yes. Rabid me, I'm walking with my husband, and my husband goes, oh, damn, he shouldn't have done that. His eyes are rolling up to heaven because what did I do? I always have Kleenex in my pocket, Miss Anal Retentive, and I went up to him and said, you need to pick that up. Right now. He did. Everybody in my neighborhood knows I'm the crazy lady, okay? So it's okay. It's okay. But don't spit on the ground. Don't spit on the ground. So tuberculosis patients, give them a disposable sputum container. You want to teach them about coughing precautions. And what is that? Cover your mouth. Mommy taught you that. Cover your mouth. And give adequate nutrition as well. The other thing also is that, yes, cover your mouth, but what else do you do? Wash your hands. Wash your hands real well. Okay. He's looking a little bit better now because we've given him some medications for tuberculosis. He's not as sick as he was. He's pinking up. Yeah, he's looking a little bit better. We've got some medications. Isoniazid or INH is one. It's the ever popular. Rifampin, ethambutol, streptomycin are also, those are the 4 main drugs that we use. There are basically 9 drugs, tuberculosis drugs, that we utilize. And now, people are going to say, damn, I got to memorize these 9 drugs. Well, let's try and make it a little bit easier for you. And what we'll do is we'll put it into we'll lump them into little categories, and you'll see what I'm talking about. Isoniazid or INH, okay? This is a drug. It's a very popular drug that's being given for tuberculosis. With INH, though, you watch and you see that with most tuberculosis drugs, antituberculin drugs, you have hepatotoxicity as a big problem. Okay, you've also got neuropathy as a big problem, and hypersensitivity. You want to watch for allergic reactions. They're very allergenic. Okay. What you might see with isoniazid is you might see vitamin B6 prescribed because it has the neuropathy component. And remember, we learned in the vitamin section that B6 you can give that you need B6 for appropriate nerve development, and that if you didn't have B6, then you can get neuropathy. Okay, so this is isoniazid. Rifampin is the other drug that you'll see. And with rifampin, it's very important for you to teach your patient that this drug may discolor their urine, their tears, their sweat, their saliva. It may discolor that and make it into an orangey color. I had a patient show up in the ER frantic. She was sure she was dying. She was sweating blood and crying blood. Okay? And I mean everything. Her urine was red, everything. She was just bleeding out of every orifice. Well, it turns out she was taking rifampin, but nobody told her. Okay, so this poor woman was just absolute frantic. Nausea can also occur, and vomiting can also occur. Now, this can occur with any one of with any of the antituberculin drugs. Okay, and hepatitis, again, it's hepatotoxic. When a patient is taking rifampin, you want to caution that person, particularly if that patient is of childbearing years and is on a birth control pill, that it may reduce the levels of birth control pills. So, you might have an oopsie baby here. So you might want to tell them to use another form of protection like a condom. It'll also reduce the levels of Coumadin or warfarin, theophylline, methadone, and yes, that ever popular, Viagra. Yeah, it may reduce the levels of that too. Do you know that Viagra is the only drug that has caused more deaths and it's still on the market? Yeah. The men won't give it up. And you all know how they die, right? Well, Viagra works because it's a vasodilatant. It vasodilates, okay? And so when it vasodilates, all the blood rushes to a particular area. So here you got these older men who've got cardiac taking Viagra. So they take the Viagra, the penis, the vasodilates and everything like that. All the blood rushes from the heart, whoop, right down there, and they fall over. That's exactly what happens. Okay. The third drug, let's get serious now. The third drug about tuberculosis is something called rifamate. And rifamate is a combination of isoniazid and rifampin. So if you know isoniazid, that it's got, hepatotoxic capabilities, and you give B6 with it, and you know that rifampin causes your secretions to all turn orange, then the same precautions that apply for those apply to this. So now you've learned 3 drugs from learning 2. Okay, pyrazinamide causes hepatotoxicity and hyperuricemia and arthralgia also. Okay, and Rifater now is a combination of INH, rifampin, and pyrazinamide. So is life getting a little bit easier for you? Okay, the panic button, don't push it yet now. Okay, it's a combination. Okay, why do we do this? An NCLEX question is, why do we do combination drugs? Well, I'm going to give you the answer. The answer is, we give combination drugs, particularly with tuberculosis and with HIV. We do this cocktail things. The number one reason is to decrease the side effects. Okay, if we decrease the side effects, then we increase compliance with the medication. All right? The number 2 reason is that tuberculosis, as with HIV, have a tendency to mutate or have a tendency to become immune to one particular drug. So if you give 3 drugs, if they become immune to one, you've still got the other 2 that are attacking it. Okay, and that's what we do with HIV cocktails as well. That's the reason. Okay, so I just gave you the answer because that is an NCLEX question. All right. Ethambutol. With the ethambutol, you have problems with the vision, optic neuritis, decreased visual acuity, and you may lose your red-green color discrimination a little bit, but it does go away. So in other words, you may become temporarily colorblind as far as the red-green is concerned, but it does go away once you stop taking the ethambutol. Streptomycin is an antibiotic, right? It's an aminoglycoside. It is in the same family as garamycin, vancomycin. Yes, you know all those things. Okay, gentamicin. And you know that with all those drugs, you have ototoxicity. Same thing here. So anytime, if you learn streptomycin, then you've also learned garamycin, vancomycin. Isn't that nice? So you watch for ototoxicity, nephrotoxicity, and hypokalemia. Rifabutin is used as an alternative to rifampin in HIV patients, and with rifabutin, you just want to watch for, signs and symptoms of prodromal fever, headache, that sort of thing. Okay? All right. Last one is rifapentine. With rifapentine, which we very, very seldom use, the biggest thing with rifapentine is the pseudomembranous colitis that could occur with it. Okay, and that's the major reason why we don't use rifapentine, because even though it doesn't have a whole lot, it doesn't turn your tears orange and that kind of stuff, and you don't see the neuropathy, the pseudomembranous colitis can occur, and that is just terrible. It's devastating to the patient. And they start off first with diarrhea, and I'm talking diarrhea of 10 times a day. Okay, and that in itself is enough to make you not take the medicine. So we try not to give rifapentine. The treatments really that we stick with are the INH, rifampin, and the combination drugs. Okay? All righty. We are now going to discuss, chronic obstructive, we're going to talk about chronic obstructive pulmonary disease. You know that with COPD, there are actually 4 of them. There's asthma, bronchitis, emphysema, and bronchiectasis. I have never seen a question on bronchiectasis in NCLEX, so we're going to cover asthma, bronchitis, and emphysema. Essentially, what you've got to know is COPD is chronic obstructive pulmonary disease. So every single one of these people is going to have problem with their oxygenation, right? Because there is an obstruction there. Okay, with chronic bronchitis, the sputum is going to be gray. This is a nice gray, well, actually it's gray here, but this is a nice gray glob of sputum. It's thick, it's gray, it's tenacious. He has dyspnea on exertion. That's what DOE stands for. He has hemoptysis also. He's got hypoxia. He's got wheezing. He's got riles, and he's just not happy. Okay. With asthma, this is the blue bloater. Remember the blue bloater, pink puffer? Well, asthma is the blue bloater. This person's in respiratory distress and has got tachypnea. He's got a cough as well and rhonchi. He's got wheezing, inspiratory, expiratory wheezing. Okay. And he's going to have more inspiratory problem than expiratory problem. Okay. He's going to have wheezing and riles as well. Okay, what are some of your interventions for asthma and bronchitis? Well, you're going to give bronchodilators. Okay. One of the things that they ask you in NCLEX is, do you know how to teach a person how to use an MDI? An MDI is a multi-dose inhaler. Now, this is a new question because I just got it in the mail the other day. Yeah, I have my little spies. When you take your questions and take your tests, you just email, let us know about them. We have our little spies out there. That's how you guys get such fresh questions from us. What, do you think we just, by osmosis and ESP got them? We have to work very hard. Okay, anyway. The question is that this patient has asthma and is using an MDI, and how do you know whether the patient is using it correctly or not? Okay, so now what you've got to do is go along with me. This is my MDI, okay? So I drop it. This is my MDI. This part goes in my mouth, and this part is the plunger, okay? So what you have to do is you have to know how to do this. So what you've got to do is say, okay, first you take the mouthpiece and put it in your mouth. Then you depress the plunger. At the same time you depress the plunger, you inhale. Is that correct? That's about correct, but you missed a whole portion. And the whole portion is that, first of all, you have to have the patient go, okay, twice. And on the third time, go. So you want that patient to empty out his lungs as much as possible before he does the final inhale. Okay? That's the best way to do it. That's how to utilize the multi-dose inhaler.